So happy to have you. Hello, you all. We are so happy to have you all here this Saturday. Today we have really special guests for me. They are from Argentina, where I live. They are from a hospital that I have classes. It's like 2 blocks from my house. So it's really important for me. And I want to say welcome for Dr. Juan, Macarena, and Alejo. Y bueno, como esto es también un Global VMR, hago una introducción en español. Son todos muy bienvenidos, estamos muy felices de tenerlos acá. Tuve clases con el doctor Alejo de endocrinología hace mucho y nada, para mí es un placer enorme. Y es eso que tenemos hoy nuestro team, we have here Maria, Shema, Ravi, and if you guys want to introduce yourselves.
Yay, I'll go. I'm Maria, and I just wanted to go first because I'm super proud of Deborah for organizing all of this. It was really funny because the first person I let into the meeting was Macarena, and I was speaking, but like vastly different Spanish. And she just goes like, "You're not Deborah." And I'm like, no, I'm not from Argentina. Like you can tell. Pero bienvenidos a todos. Gracias por venir. En serio, esperamos que pues, les guste la actividad, se sientan como en su casa. En serio, esta es su casa y pues estamos listos para pasárnosla bien. Shema, do you want to go next?
Hello, everyone. I'm Shema, and I have such a big love for Global VMR, especially was the first format. I felt really comfortable as a non-native speaker, and I'm so excited for today with Argentina.
Ravi, do you want to say hi too?
Oh, hi. Yeah. I was talking in the background with them before, but I'm Ravi, long-time CPS admirer, and really happy to be a part of this group here, know this group, and work alongside with them. And I'm a big admirer of Argentina, especially big soccer fan. So the Argentina national football team and Maradona. So I'm very happy or very enthusiastic to hear your case today.
And Marcela, you think you can hide, but I spot you. You want to say hi too?
Sure, thank you. Hi, everyone. So my name is Marcela. I'm a doctor from Brazil. I'm so happy to be here. I love Global VMR, and I'm really excited to learn more about Argentina and to learn more about the case today. Thank you.
Wonderful. So hi, everyone. My name is Robbie. I come with a crazy dog. We are a package. He will bark constantly throughout, but hopefully he'll be mildly respectful. It's a delight to be here. I wanted to thank Deborah for all the work she put in to make this event happen. And the word Argentina for me triggers a beautiful set of colors. My two favorite colors, actually, blue and white. But also, I have so many fond memories and connections with people from Argentina. I first got introduced to the Argentinian love for meat from a friend who in med school who would just do the most incredible barbecues. We would hang out at his place, and oh my God, I was like, you are literally like, you must be born in paradise to be able to put this food together. It was incredible. But the truth is, I think my peak moments of joy, like those seconds of happiness that are very elusive and never, ever no you can reproduce, are watching Messi play soccer. Like seeing him play live and doing his thing. So of course, no individual bears the representation of an entire nation of millions of people, but both his humility and his grace and his ability to do magic. It can't be a coincidence that he's from your country, heaven. So it's a delight to have you here, and we're very, very grateful for it. What we're trying to do is get to know you all in and outside of a case. So maybe we can start by having our guests say a quick hello, and then we'll jump into the case and try to let your stories and as they relate to where you practice medicine emerge as we go through the case. So Maybe Macarena, you want to start off by saying hi and we'll go from there.
Okay, hola, hello to everyone. I'm Macarena. I am a resident in cardiology at the teaching hospital, Hospital de Clínicas José San Martín, which is in Buenos Aires, which is the capital of the country from Argentina. Like I said before, I appreciate this invitation because I think it's a very great idea. It's useful, and I will love it if I would love it if I have this kind of thing when I was a student. So I appreciate that you are doing it now. So thank you everyone to the invitation.
And that is very kind, Macarena. Thank you for joining us and for your kind words. Juan, do you want to say hello?
Yes, of course. Hello to everyone. My name is Juan Martín Ortelendi. I'm the chief resident of cardiology service in Hospital de Clínicas San Martín, José San Martín. Well, if there's some noise, sorry that there are my two kids around here, but well, thank you very much for this opportunity for us to show away what we do, some interesting cases that we have. We have lots of patients here. We see different realities inside the country. In this hospital receives lots of people from the inside of the country, from different provinces and all that, and we have a big number of pathologies and different kinds of patients. So it makes it really interesting. It's a university hospital. It depends. The hospital depends from University of Buenos Aires, de la UBA. So well, we try to go further in all academic stuff. And thank you very much for this opportunity for us. And of course, whenever you want, we can see a Argentinian match, of soccer match, and we can have an asado, a barbecue, of course.
Yeah, asado.
We will receive you.
That is very, very kind. Thank you so much, Juan. And Alejo, I know your goal was to be as silent as possible, though I don't think we'll let you do a good job in that domain. Do you want to introduce yourself and tell us more about you?
Hello, how are you? Okay, just a quick word, because I want the focus to be on the group that you are and on the residents. I'm merely the contact that Deborah had to organize this, and really I want to thank all the work of Deborah organizing this meeting, because it's not easy to organize anything with me. I'm very slow at answering emails or even picking up the phone, so she had to be very polite and very persistent. But it's truly, I believe it's a beautiful experience to have this meeting. I hope that we are up to the task of performing okay. We are here to represent our hospital, our university, and of course also our country. I don't know if we are Messi. Maybe he's better at representing us, but we'll do our best. I studied at the University of Buenos Aires. Since I'm a student, I've been at the Hospital de Clínicas, where I also did my 2 residencies in internal medicine and cardiology. Then I was chief resident of Juan Martín, and now I'm an attending physician at the hospital in cardiology. So I'm very, very proud of the hospital, and I hope we represent it at its best. So nothing else for me to add. Thank you very, very much for this invitation. We're really very happy to be here.
You know, I thought Messi was the most humble person in the world, but you've already said your goal is to say nothing and are a shining example of humility, but also being honest about your email and phone skills, which I probably share, to be honest with you. But maybe, Macarena, you can start us off with the first part of the case, and we'll continue to learn more about the patient, you guys, and and your hospital.
Nice. Okay, let's go. We're present today a patient with dyspnea. That's why he comes. And the problem presentation of the case that we were working about a 49 years old man who lives in the north of Argentina, and he complains of dyspnea, which starts 5 months before he comes to the hospital.
Ooh, that, you know, that's our. Oh, sorry. Did you mean to stop here, or do you want to give more information? You're whatever.
I can give you more information.
Okay, let's do
it. About his history. He was a mild past smoker, and he had mild COVID disease at June 2021. Then he completed his COVID vaccination, and he was admitted at a hospital because of an acute bilateral bacterial pneumonia at November 2021. And least but not last, he and his family have serology tests for Chagas positive. He was diagnostic upon entry into the military service, like 30 years ago, the date of be admitted at hospital.
Wow, you've given us so many threads to explore. I think it's very clear from your presentation that the problem that we're trying to solve is chronic dyspnea, and the clues that you're giving us are that this patient smokes, had COVID, had pneumonia, and has a Chagas history. And maybe I can ask the chat to focus first on one thing, which is what changes when the dyspnea becomes chronic? So let's reflect on that. Most people with shortness of breath come in days or weeks into their shortness of breath, not 5 months. And Ravi has begun to reflect it. So I'll lean on you. What do you all think about the fact that this is chronic, and how does that change things for you? In the meantime, Macarena, do you want to tell us, while the chat thinks about that, do you want to tell us what's the general theme for preventative or primary care in Argentina? Are patients like him usually seeing a doctor even when they're not sick, or do most patients come to attention when they are ill?
In Argentina, we have a scene like is, I think, common in all Latin American, that we have a big two group of socioeconomic population. So maybe the poor socioeconomic population, it's very difficult work in prevention in that group, and usually comes to hospital with advanced disease. So it's for physicians, it's they come with clinical cases, very complex, very chronic, and we say floridos, with a lot of signs and symptoms. And then we have the other group of population that are the wealthy, for one way to say it, which have more prevention work, and they come to hospital to annual test and check with their doctors. And in the first group, it's very difficult work with prevention because they don't have the tools, because we don't have the contact with them before the illness. So it's like a very complex subject here.
Yeah, no, it's incredible. Thank you for sharing that. It's incredible how much those words get played over and over again across the world. It seems intuitive. It seems like, oh, I bet that's the case everywhere. But hearing it from many corners of the world, people saying very similar things, how primary prevention correlates with socioeconomic status. It's a good assumption to make, but I think these reflections with you are bearing it out. And meanwhile, the chat has been throwing a lot of wisdom. So I'm not sure if Ahmed is able to unmute. He made an interesting observation about disease severity. Are you able to unmute, Ahmed? I don't think he's able to, unfortunately. Marcela, do you want to share your thoughts? I think they're very interesting.
Sure. So I was thinking, like, when we think about dyspnea, especially chronic, we think more about the heart or the lungs. And so I would try to ask some questions to clarify if I would prioritize the lung or the heart. So like the level of effort that the patient starts feeling dyspnea, or if it's respiratory, like if you have some pain or something like that. And since he has a history of a family of Chagas history, so maybe if he Chagas positive, like a dilated cardiomyopathy, and he's a smoker, so is he a smoker for such a long time, and how much does he smoke, or if he has exposure to other type of smokes, so he could have COPD or something like that, or a malignancy or other lung disease.
Incredible. That is so powerful. Thank you. Nikita, you had some thoughts too. Are you able to unmute and share your thought?
Hello. Just like how Marcella shared just now, I had the same thoughts too. I thought about chronic diseases associated with the lungs and the heart. Chronic obstructive pulmonary disease came in first in my thoughts, just because I do understand he's 49 years old, but I'm intrigued to know how long has he been smoking for? Because in the cases that I've seen back here in India, we have seen 50-year-old men with COPD too, and it's just because they've been smoking for a long time, say since they're 12 years old. So I'm intrigued to know about his smoking status and also the kind of work he does every day, because maybe he's a sedentary man who doesn't really work a whole lot. So that's why he let the dyspnea go, or else maybe he does not really I mean, one thing that I face a lot is healthcare literacy too, because a lot of people are not very aware of, their condition. So maybe that did not really compel him to go to the doctor. But also knowing that he's someone who's been diagnosed with COVID, pneumonia, and Chagas, it's not that he's hesitant towards the system. So I'm intrigued to know where this case goes. So yeah, that was my primary thought. COPD.
Very illuminating. Thank you so much. Angelita has some fantastic questions. Angelita, do you want to tell us what is prompting you to ask them? I know we'll get the answer later, but what made you ask these questions? I'll wait to see if she can unmute. I just make that assumption for everybody. Oh, no worries at all. I don't think she can mute, which is actually a good time to maybe ask Juan Martin and you feel free to speak in English or Spanish, whatever you're comfortable with. I'm curious if you just if you can shed light on the one dimension, which is that nobody else can know except you all, which is Northern Argentina. As soon as those words come into your ears and you hear them, how does that change the analysis for a case in general? And then maybe how it changes a case of shortness of breath for you. You want to shed light on that for us?
Sorry, can you repeat the last part? Because
of course. So
yes.
I'm just curious, even if before you know what the chief concern is, when you hear somebody's from Northern Argentina, how does that change the medical landscape for you?
Well, actually, it changed a lot because, well, sometimes the northern part of Argentina and the northeast part, but both parts are like they have lower how to say recursos. They have lower incomes, but in general, from all they are like poorer provinces. The middle of Argentina, the middle side of Argentina, like is Buenos Aires, Córdoba, Santa Fe, Mendoza, like that slice. They have better outcome incomes because they are more productive, especially because Argentina has a lot of exports, a lot of agriculture things, and the most productive area of Argentina that produces more in the countryside are those provinces. So in the northern and in the southern part, there are like differences. The northern are poorer, and the south is all the Patagonia that sometimes maybe you sometimes you will heard about.
You
it.
heard out.
Yes. The south, the Patagonia, it's a very touristic area. They have a lot of mountain lakes and there's a lot of tourism. So it's and there's less population. There are like more spaces with less people. So and it's more touristic because in winter it snows and everyone go to ski or snowboarding or the things, and in summer it has like the lakes and the mountains, and it's also very nice. So in this, digamos, structure, we think that when someone came from the north of Argentina, probably it has less incomes or they are poorer. So they are sometimes more related to rural areas. I don't know how to say it, but and
okay, you can say it in Spanish. There are many people who in the chat.
Sí, más gente rural, sí. So there are some like diseases that we thought about them. So, for example, if someone came from the north, we asked if they had Chagas, and we do some serology of Chagas. And well, in this way, I don't know if Deborah from I heard you speaking. I think you are from Brazil, no? If I'm wrong. The Chagas is not the same in Argentina that in Brazil. They have different, digamos, different impacts of different organs, different systems. In Argentina, we have more, the Chagas goes more through the heart, and in Brazil, it goes through the digestive system, all right, like megacolon tóxico and all that. And so, well, one of the diseases we thought of the north of our country is Chagas, for example. Other are all the diseases that are related with parasites and more endemic things. And sometimes we also have, and most in the northwestern, like near Bolivia and near Peru, in that area, we have more like tuberculosis. So if it depends from where the patient comes, we think of different diagnoses.
Juan, I learned so much from your reflection. I think the first is, it's incredible how education in the United States, medical education, zooms in on specific things. For example, we think of blastomycosis only in certain part, and so on and so forth. And that is a truth that resonates across the world, because productivity, socioeconomic status, and infections don't necessarily respect international borders and boundaries. And the nuances within a country are so fascinating, let alone even changes in the behavior of a parasite and the subspecies of a parasite. It's just so fascinating. Maria, did you want to say something? Go ahead, please.
Yeah, I just want to share a story because I found it fascinating how you described like the geography so well. And I was going to tell you that when I was in second year of med school, I started taking semiology, and I had like classes with like this very old school doctor that like you have to have like your perfect uniform, be on time, things like that, right? And he always did like these questions, and we were always terrified because nobody knew them. And then like the first day I went to his class, he told me like, can you draw a map of Guatemala with all of the locations? And I was like, shoot, like I didn't study that, and I'm super bad at geography. So I was like, it was really funny because like it was my country. I've lived here all my life. And I was just like, and then like I managed to do it. And then he's like, can you do rivers? And I'm like, oh my God, I know like one or two. And then he's like, can you do volcanoes? And I'm like, this is starting to sound like a joke. And then like at the end, I grew really fond of him, and he was like, okay, so we're not gonna learn any semiology until you learn where are you studying medicine. So go back, and then like everybody come again next class, and we're gonna discuss like the geography of Guatemala, and then like go see patients at the hospital, not before. And it right now I couldn't even draw a map of like anything, but it's really stuck in my head for the longest time. So I love that reflection, Juan Martin.
That's beautiful. Wow, what a way to emphasize that that point. You know, I think we'll move on, and we'll move on because it's really important to recognize that the words shortness of breath are so alarming, that everything that we're studying now in terms of clues are really side pieces. Everyone with shortness of breath is going to get an extensive evaluation. What that means is they're going to get imaging, EKG, and probably blood work. So these peripheral clues only really become valuable once you have clarity on the nature of the shortness of breath. Is it a cardiac problem? Is it a pulmonary problem? Or is it a hematological issue? For example, you might start to say, oh, I believe that this is cardiac, so I'm going to look more into the Chagas. Or wait, I believe it's more pulmonary, so I'm going to investigate the history of COVID and pneumonia. Or wait, no, this is a purely hematological issue like anemia or acidosis, so I'm going to go explore those landscapes. So for now, all these things are going to be peripheral clues, but we have to wait to clarify the problem. So I'll give the mic back to Macarena to give us more information.
Nice. Okay, go on. About the complete history, he started 5 months before the comes to the hospital, like I said, and he has progressive dyspnea until he had addressed by the time he come. And in addition to that, he also have orthopnea and paroxysmal nocturnal dyspnea. And in the question with the patient, he denied peripheral edema in the evolution of the disease, or increase in the need of urinate during the night, or he denied palpitations or something like that. So that was the illness, how he come. If you want, I go on with the physical exam. Okay. So when he comes about the vitals, he comes with 110 and 60 over 60 about blood pressure, 110 of heart rate, and 20 of respiratory rate, and 36 Celsius degree of temperature, and least O2 sat of 97%. And the general examination, he was lying supine, looks comfortable at bed, he has a normal body habit, and he was oriented, alerted, and connected. About the cardiovascular exam, he has fast heart breathing, fast heart rate, sorry, and normal heart sound, but in addition, he has a third heart sound, like gallop rhythm. He has jugular ingurgitation, and there is no evidence of peripheral edema. About the lung exam, he has good bilateral entry of air. He has normal circular sound, and he doesn't have crackles or any sound, pulmonary sound. About abdomen and neurological exam, he doesn't have any remarkable finding. And that's it for now.
Incredible. Macarena, did you see this patient, take care of this patient directly?
No,
Okay.
no directly, but it's a common presentation of a lot of patients.
I see. Where do you see patients usually? What is the context where you see patients? In the
At
hospital
hospitals.
clinic? In the hospital.
I work in the hospital, and also I have contact with clinics. I see both work.
And can you give us a sense of what your schedule is like weekly? How does it change?
My schedule. Okay.
Yeah, like how often in the hospital, how often in clinic, and yeah, just a sense of what it's like in your medical life.
Okay, I have my 90% of the day in the hospital, and then some weekend I work at clinic. I wake up like 6 a.m. I live far from the hospital, so I have to travel a lot. So I don't know, I wake at like 6 a.m. and I spend all day there. Perhaps I back to my house at 7 p.m.
Wow.
5, 6 p.m. And in between I have like one guard per week. I have yesterday a guard, so
nice.
I looks very well
You know, I'm just in awe of how well you're able to speak English and present in English. Where did you learn English, and how did you learn English?
It's a funny story. I learned some in the school, and I have a boyfriend from New Zealand, so he teach me a lot.
Both personal and professional ways to learn English. I love it. That's awesome.
Yeah.
I'm sure that unless your boyfriend is a medical, that he doesn't know what orthopnea means. So you probably had to learn that on your own.
Yeah. But apart from that, the accent, he has a particular accent. I don't understand nothing. So I have to learn a lot.
That's incredible. Oh my God, you're gonna make me die. That's so cool. Okay, so what I was trying to get at was just trying to understand what your life is like and how hectic it is clinically. And it seems like it's a lot. The other thing that it was very powerful when you said, very few people have said this on VMR, 650 episodes in, he was lying supine. And that made me think of two things. One is medical and the other is non-medical. And I'm just curious to ask you, Juan, what's the relationship really like with a physician and a patient in Argentina on average? Is there a distrust of the medical system? Is there a lot of trust? Can you, as a doctor, just walk in the room and start examining somebody, or is there a lot of setup to that? How does that dynamic usually go?
Well, first of all, we in the residence we do a lot of assistential work. So we have like intensive care from UCO, coronary intensive cares. We have some patients that are inpatient from clinic. I don't know how you said salas. I don't remember.
Say it in Spanish.
You can say it in Spanish.
Digamos, las salas de clínica médica. Also that they ask for some to see some patients, particular patients that have some cardiovascular thing that they would like to consult with us. And we also see ambulatory patients. We have one evening we dedicated to see patients. This is during the residency. So we see our spectrum of patients it's really wide, and particularly the way we are with the patient, it's like really natural. Here we we work with respect, but we like have I don't know how to say it, some Latin blood, so we are like really close to each other, and we
passionate. We're passionate.
Yes, we don't have a distance between the in the treat of everything. So we can speak of every of we can speak about everything with the patient, always with respect, but the patients are really, digamos, they are close, and we can touch them, we can ask them, we can like come to the to the room and start speaking. Hello, I'm from a cardiology service. I can I do an examination? I'm going to make you some questions, and they also know that in our hospital it's a university hospital, so it's also like it's a way of learning, and they know, so they are like permissive in that way. So we don't have problems in go and touch a patient and do a physical examination and talk to them, and like we and sometimes we do like really close relationship with some patients. I gave my phone number to a wide number of patients, and some of them I give you I don't know, I do the consult, and then I said, well, this is my number. When you have the results, talk to me, or this is my mail, or you can find me here in this area. Every morning you talk to the secretary, and she will find me, and I come here, and you can show me your results. I think in the hospital we work like this. I don't know if I'm clear, but
You're very clear, very, very clear. I see Alejo is also unmuted. Go ahead, please.
No, Ravi, only to expand a little bit on what you just asked us. Maybe what Juan is describing is a very good description of what happens once the relationship with the patient is an ongoing relation in the hospital setting. But you asked about the distrust with the medical doctor institution, and this also happens. We see maybe two different approaches on this distrust. One is when we are with patients maybe with higher incomes, that they come more belligerent to the meeting, and it takes a different approach to get to that relationship. Most of times we really get to a better relation, but that happens. And what happens with patients like this that we are describing is that maybe the distrust come from the fact that they've been having different consults and there has been not a good response, or maybe a clinical response that made them travel almost 1,000 kilometers from where they live to Buenos Aires to get an answer for the problem they've been having. You signal at the first of the clinical presentation that this patient had 5 months of dyspnea. Maybe he did consult earlier with the dyspnea, but it took him 5 months till he got to an institution where this problem could be thoroughly evaluated. And that is a sad reality, but a reality in our country. I imagine maybe this in bigger countries or poorer countries like ourselves, this is seen more frequent than we'd like. And this maybe is the reason for some distrust also with patients. But we tend to get into relations that sometimes border with personal relations, but it's in our way of being.
You know, this last 5 minutes have been such a profound reflection, with Juan sharing that he gives his phone number to a number of patients, which is incredible, but also the reality of the complex life with such extreme socioeconomic distance, and also access to care. I think that is, I feel much more connected and understand the landscape that you have. And for the sake of time, I'll analyze this dimension of the aliquot, then pass the mic to Macarena. And I think that whoever did this exam, which is why I asked Macarena this question, did a phenomenal exam, because they've essentially diagnosed the patient with one thing. The presence of an S3 gallop has a likelihood ratio of over 10 of predicting the presence of congestive heart failure. And so this patient basically has congestive heart failure. And the questions that we'll have to ask is, what is the cause of this congestive heart failure? One, and is there anything else going on? Because we know the patient has CHF does not mean they don't have anything else. And the frame that we have to analyze this patient from is what is common. And it'd be so curious to know what is common in Argentina, but what is common in the world is coronary artery disease. That's by far and away the most common. Hypertension is a close second. Valvular disease, like rheumatic valvular disease, is an important consideration. And the differential diagnosis is very long, but base rate, what is common in 1,000 people in Argentina, will be very informative. But then also using the clues unique to this case. How does the history of COVID influence the analysis? How does the history of Chagas in the family, what does the bacterial pneumonia have to play? But I think the next steps are to recognize that the labs and the imaging will reinforce the suspicion of heart failure, but won't tell you what the nature of it is. And so that the nature, the cause of the heart failure will come with advanced diagnostic testing. And so I'll pass the mic to Macarena to give us the next aliquot.
Okay, let's continue. And about the labs, he has white blood cells in 8,100. His hemoglobin was in 17. 17. I don't know the units, but I think it's the same unit. Plaquettes are in 161,000. And the renal function was normal with uremia 51 and creatinine 1.15. About the sodium, he has 140, potassium 3.6, and chloruro 101. Then he has acid state. That was normal, all the variables, and except the lactic acid, it was in 1.8, like is the upper limit value, little above the upper limit value, and the cardiac cardiac troponin CK, it was in 50 and troponin in 11. That was in the normal value for us. That's about the lab. And then we have some image that if you let me, I can share so you can see it. Can I do it? Can I share? Okay. This is the ear X, right? And here we can see a clean lung without consolidations with pathology. And then we can see about the cardiac exam in the RX that is enlarged. It's more than 50% of the thorax, and have like enlargement of the right atrium, and it seems like a biventricular enlargement too. And that's the difference between the right and left. It's about where is the apex of the heart, but they don't have signs of pulmonary edema. It has the sinus are clean, the costophrenic and cardiac. The cardiac phrenic are clean too. I think it's very visual, this image. It can tell a lot. And then this is the EKG, where we see a sinus rhythm, like 75 hertz
Maca,
rate. Yeah, sí.
perdón, se ve la presentación del PowerPoint, no se ve la presentación, se ve, digamos, el PowerPoint abierto.
Ok. Porque debía haber puesto el de EKG, you can see it. Okay.
Now, yes.
Okay, so it's a sinus rhythm, like 75, like I said, and P wave and PR are in the normal values. QRS is enlargement, it's more than 120 milliseconds. And like pathological finding, it has, let me see, because it's the translate is not easy of that. So I have a machete. It has a left anterior ME block, and it has two a complete right branch block. That are the more remarkable findings on this EKG. That means a lot. Okay. If you wanna continue sharing.
Macarena, you have
Yeah.
made my own heart stop, because I'm really worried about this patient. He's 49. He's 49 and has this EKG. That's not good.
No.
So
No.
as always, I talk so much that we only have 10 minutes left. So here's what I propose. I think I would love for the chat to share their thoughts on this, highlight one or two people's thoughts, and then I will share my thoughts, and then we'll come to learn from you, our dear friends, what you think is going on and what you can teach us about this patient. And I see that that Shema is sharing some interesting thoughts in the chat. Shema, do you want to unmute and share them?
Sure. As we know, as a late complication of Chagas, it affects the electrical system of the heart, and we have a right bundle branch block, and also a left anterior hemi block, so which makes me think more of Chagas as the culprit here.
I think that is absolutely superb, my friend. Absolutely superb. I'm seeing that basically a lot of people are reinforcing what you are saying. So I instead will share a zoomed out reflection. And that zoomed out reflection is, ask yourself, how do we actually diagnose the cause of heart failure? Like, what do we do? For patients with the common causes, we see for patients with common causes, for example, ischemic heart disease, we do an angiogram or non-invasive tests at looking at ischemic disease. For valvular disease, the echo is great. For pericardial disease, the echo is great. For myocarditis, the imaging, including up to an MRI, is great. But there are basically many different ways to diagnose heart failure, but you cannot ignore clues. And the one clue here is the arrhythmia burden. The arrhythmia burden is evocative of one diagnosis called arrhythmogenic cardiomyopathy, or ARVC. But that is an example of how some patients with some kind of heart conditions tend to have more arrhythmias than heart failure. And the term arrhythmogenic cardiomyopathy is actually not a good term, because it makes you think that that's the only condition that can cause a lot of arrhythmia. In fact, there are a few conditions that cause a disproportionately high rhythm burden. Now, let's be clear. Any cause of heart dysfunction can affect the conduction system and can affect the rhythm, any cause. But which ones are probabilistically more likely to? And here they are. Sarcoidosis is notorious for causing bradyarrhythmias and ventricular arrhythmias, and its acute cousin, giant cell myocarditis. There are a variety of genetic diseases that have a disproportionate effect on rhythm, including ARVC and many others. the list of infections is also notorious. Lyme disease, Borrelia burgdorferi, only causes conduction system issues. Overt cardiac dysfunction from Lyme is very rare. And there are some others too. And then, you know, the twisted trifecta of amyloid, acromegaly, and scleroderma. So what would this EKG do? This EKG would reshape this case to say, this is an arrhythmogenic cardiomyopathy. And I worry more about these diagnoses. And I think you both have to proceed quickly, but also carefully. This person is from a Chagas endemic area. We learned from Juan to think about Chagas. And what will prove that it's not Chagas? His antibody profile will likely be positive. And so you have to be very careful. I can see a scenario here where he has been exposed to Chagas and has Chagas cardiomyopathy, as was alluded to, full stop. Or he has incidental Chagas and something else. So this train is moving so fast towards Chagas that in real life, you have to stop and take a breath and say, wait, does he have something else and incidental Chagas? But otherwise, I completely agree with Shema. This case is very concerning for Chagas cardiomyopathy, but the fact that most people who have Chagas antibody positivity don't develop Chagas cardiomyopathy, only 20 to 30% do, gives you a little bit of pause to say, wait, I don't want to miss any additional clues of another cause. But the truth is we're probably going to go in that direction. We're definitely going to learn a lot from our friends here. So I'll pass the mic to Macarena and then the entire rest of the crew to take us home.
Okay, I go on with the diagnosis. Okay, yeah, the final diagnosis was a new onset of myocardiopathy, of Chagasic myocardiopathy. That's right. Everybody were very good on that. And like you said, it's very uncommon, the cardiomyopathy, because of Chagas. Just the 20% of the chronic Chagas, which is represent the 20% of the infections, arrive at the myocardiopathy. So you think that EKG that you saw is not common, or you get alarm about that, but we saw a lot of Chagasic people who have that EKG and they can live for a lot of years more. It's very common. Even we diagnose the most of the time we diagnose Chaga because we see the EKG and then we ask for the serology test. Even nowadays that we are so globalized, that you said, like you said it before, we can find a lot of people around the globe who has Chagas. And even I was reading that in United States, you have a lot of cases because of transfusion acquired. I don't know how to say it. You acquire the illness because transfusions. So I think it's an interesting case in a young patient with this advanced cardiopathy.
Absolutely superb. Not only are you presenting a case in English, you're also teaching us in English, which is amazing. And maybe we can pass the mic to Juan and Alejo to teach us what they know, how they think about these cases, and pass the wisdom on from Argentina.
Yes, of course. Maca, do you have the echocardiogram of the patient? So while we are
Déjame prepararlo. Si quieres hablar, yo mientras lo voy preparando. ¿Te parece?
Dale, perfecto. So as we are talking, we can show you also the echocardiogram, because it's really interesting, this type of pathology. It had both arrhythmic disease and heart failure disease. It's through the direct influence of the parasite in the myocardium that involves the conduction system, electric conduction system, that makes this right complete right block change, and this anterior left block, and also and this and well, sorry, the arrhythmogenic wave from one side, and the other side is the heart failure. It makes a dilated myocardiopathy, sometimes with very low ejection fraction that makes a severe cardiac insufficiency, and it sometimes make an aneurysma of the apex of the I don't know if we can see, but
I think are you talking about the aneurysm of the LV apex? Is that the?
Yes. So in these two ways, it also the parasite affects the myocardium myocyte, and this makes fibrosis. So it's predisposed also to major arrhythmic events like tachycardia ventricular or ventricular tachycardia or ventricular fibrosis, fibrillation. Sorry. So this patient with dilated myocardiopathy and arrhythmic sustrato arrítmico, it makes this patient, young patient, less than 60 years, with a very high risk of cardiovascular events. So, well, finally, we decided in this patient that he has to have implanted a cardiodefibrillary implantation. It's really interesting. If you want to see the images, you can see that there is a left ventricle that is dilated with not thick, that thin walls, and with some mitral regurgitation because of dilatation of the annular of valve annular of the mitral valve. So it makes a secondary mitral regurgitation. Well, this patient is really complex. I don't know, Alejo, you are the one that knows most of us in this aspect. So I don't know if you want to say something more.
No, truly, I think Juan has said almost everything that there's to be said about this patient. Ravi, I was very gladly surprised of your amount of knowledge on Chagas disease. It's a disease from all Latin America, and it's a struggle of every day to make this more known disease. It affects over 3 million people in the world, almost all of them in Latin America, although, as Macarena said, it's starting to be present in other countries where there is no vectorial transmission of the disease, because you don't have the bug that transmits the parasites, but as it can go from mother to child or through transfusion, it's starting to appear in different countries. As you very well said, it's not frequent, the myocardiopathy of Chagas, and most of patients that have serology for Chagas will never develop this kind of disease. Although when you think that we have over 3 million people living with Chagas, 20%, it's a lot of people. Sadly, we do see a lot of these patients. It's also important to remember that in the acute phase of Chagas, which is more frequent in kids and adolescents, it is treatable. But because of what we already spoke before, that the acute phase usually happens in places where medical attention is not easy to get, it goes by undetected, and we found people in their 50s with this kind of myocardiopathy. And then there's the other problem. As Juan Martin said, as you can see in these images, there's no evidence of an arrhythmogenic cardiomyopathy, like, for example, you could say right ventricle arrhythmogenic cardiomyopathy, although it's a very interesting differential diagnosis. We thought as Chagas disease as the main culprit in this kind of patient, and we had to take the decision of implanting an ICD for prevention of sudden death due to ventricular dysrhythmia. But also, this patient needs probably will need a heart transplantation along the next years, and this is also very, very difficult in our country. We don't have good statistics of heart transplantation. It's not easy to get donors, and that I believe is a problem in a worldwide scale. But we also don't have enough technology like to offer this kind of treatment in every city. In Buenos Aires, we have a various number of centers that can do this surgery and take care of these patients, but in the rest of the country is much more difficult. So I believe that also very interesting case, and I want to thank all the residents that participated in elaborating this, and also again to Deborah. But I believe that the most important reflection is this could have been avoided. This is an endemic disease, we all know. This could have been treated in the early stages, and we are seeing the consequence not only of the parasite effect, but of the social environment of this patient.
This is Leo, this is such a profound reflection, and I think, you know, for those of you who are on Twitter, I shared this reflection recently, that our job really comes down to three things, and the first of those things is what is happening to this person. And in this case, we had the opportunity to review our approach for shortness of breath, and to use the powerful tool, the exam, to say this person has S3, so it must be heart failure. And then we merged that what is happening with who is this person. And we learned that this person likely comes from an area with low socioeconomic status and exposure to a hyperendemic condition, Chagas cardiomyopathy. And we merged those two together to come up with an answer and a proposal as to what's happening. But the final part of those three things is what is happening, who is this person. The final reflection is, who are you? Who are you taking care of this patient as the doctor? Because even though we like to think that all care is the same, a patient shows up, a diagnosis is made, it profoundly matters that you are Macarena, that you are Juan, and that you are Alejo. And what we learned about, we learned a lot about, we got to practice again our approach for shortness of breath. We learned a lot about this patient and his unique risk profile. And we learned a lot about you three. We learned a lot about how hard you work, about how somehow you were able to present in a language that is not your primary language. We learned about how you, how personal you get with your patients and how close you get by sharing your phone, and how caring you are about them. And we also learned about how reflective you are about how preventable this is and how we could have all done better. So I think I learned a lot in this hour about all those three things, but most importantly, I'm very grateful for the lasting impact that you three will have, because, you know, we'll think about heart failure again. We'll probably be tested on Chagas and maybe even exposed to Chagas in the future hundreds of times again, but I'll never get to bask in the wisdom that you shared with us. So thank you, really, really, thank you. I'll stop talking, as I always do, and hand the mic to Deborah to reflect and to also honor her work that she's done to make this happen.
Thank you so much. It is a really interesting case. Even that I live here in Argentina and I'm from Brazil, I learned a lot. Yeah, we are super happy. It was a really great case. I guess Ravi asked a lot of questions about the medicine, the work that you all do it. So if someone has a question, we are already talking about Maradona, the meat, or I don't know, can be a medical question or a not medical question. I guess I can ask like, what motivated you all to work every day, to do this work here in Argentina that is not easy? So if you all want to share something that makes you happy and motivated to go to the hospital and do this amazing job, we would love to hear.
Maca, do you want to speak or I speak?
Go on and then I talk.
Okay. Yeah. Well, I think that the thing it makes me go to hospital every day, it's because, well, first of all, my family, all the people that I love, the people that have needs also, there's some occasion for the service. And also because I think I love my country. The Alejo, I think, represents very good all, and Macarena also, all the different circumstances that that we live inside this country, and I think it's a way of making this a best country. I really love it. It hurts to me when I think I see things that I don't like. Don't know, some politic things or some other things that really bother me. And sometimes I said, oh, I would love to go to another country, to Europe, to another place, but there's something that makes me stay here, and I love this place, and I think that makes me stay here and be a doctor. I think that's the final end of all this.
Well, in my particular case, I think that medicine is a kind of help people, not just in the medical stuff properly, also in the, be with the people, the suffering people, with their family. And I think it's a very passionate way of work. And I think in particular is that what it's feel me in day by day. Particularly in the hospital, we have a very good academic program. So I love both the sentimental way and phase, the sentimental phase and the academic phase. So really, even I spend a lot of hours working. It's more like a passion be there. I love it. I don't do it like like a punishment. No, I do it because I want it. Anyway, I'm doing the second residency, so you can imagine that, or I'm crazy, or really I like it, or both. I don't know.
I just love the idea that you were humble enough to recognize it could be both. I know Alejo's sole job is to not say anything, but I'm going to ask him one specific question. But first, I just want to highlight one thing, which is that whenever we get together on an international platform, two things happen. First is the default language tends to be English, which is a shame. I think that that's a reflection of a colonial area gone by, and I'm really appreciative that we're slowly eroding that and working on introducing other languages in this space. And I'm sure that one day in the near future, I will sit here and not understand what most people are saying, and I look forward to that day. But I think more importantly, I think, Juan, what you did, I don't know if you realize what you the impact of what you just said, Juan, because I think whenever we get together in this space, there's the sort of preconceived notion that the ultimate medicine is practiced in places with resources like the United States and Europe, and that everyone, if you are at all aspirational as a physician, that you should aim to come to these places to be the best doctor you can be. And I think we believe that that is not true. That I think what you're able to do in all over the world is just as noble and just as amazing as anywhere else in the world. And quite honestly, I think as my personal bias, I'm more inspired and more in awe of people who keep the roots growing where they were first born. I think that is harder to do in many ways. It's maybe not harder. They're not direct comparisons, but it's very hard to do. And I'm sure that there are moments when you're like, oh, I wish I could just uproot and go somewhere else. But the love and passion you have for the soil that has nourished you is very inspiring. And I'm really, really glad that you emphasize that today. But on a maybe less serious note, can I ask you one question, Alejo? So if we were, or this entire crew were to come visit you in Argentina today, what would we do? What would you have us do for one day?
For one day?
Yeah, just one day. What are we doing?
It's very difficult because, well, there's the Argentinian poster, as you can say. We can eat meat and dance tango. Now, then there's the reality. I almost don't know anyone who dances tango, so we can go all and watch, but I don't know how to dance. I don't know if Macarena or Juan has any kind, or Deborah has any kind of skill in dancing. I could only amputate my left leg if I try to dance tango, so I'm not going to do that. We could also say, let's go see a football match. For those who live in the US, football for us is what you call soccer. And well, I believe that the most beautiful thing that we have in Argentina is our people. And I would definitely suggest to get around with the friends of those who host your visit and make an asado. That's the true name of a barbecue. And eat and drink wine or water or whatever and share experiences. You'll find a very open people to share experiences and thoughts and opinions. And maybe that's the most rich thing that you can do coming to Argentina. If you have one day, if you have several days, then we can learn to dance tango, go see a football match, and all the other things that are listed in the Argentinian poster.
Alejo, for just to start, like that was an amazing answer, but I just wanted to say, Robbie, that is such a if I can say it, like an American question. Just one day, like you don't understand Latin culture. Like if you come for one day, like we are just gonna have like a nice lunch wherever you are, and then sit in that space for 6 hours and not move and just talk about life. And when you realize day's over, you didn't do anything other than eat and talk with people, and then you're gonna like, oh, this was a great day in Argentina, right, Alejo? Or am I wrong?
No, right on. That's the key. I believe I'm learning that that's the same in all Latin American countries. We like to share experiences, eat and talk.
So true. So like no rushing in 10 activities in a day.
Amazing. Oh, well, I'll just tell you that it just tells me and tells a lot of people how important it is, how much you value the people, not the place. And I think that the fact is that you're just sitting, you don't really care what you're doing. You don't really care where you are. You just care that you're around a group of people. And that to me highlights the single most important thing in the world, which is to be present. And we're very grateful for you all for the last hour and 17 minutes to be sitting here present with us. I'm sorry that it doesn't involve delicious food and wine, but maybe in the future it will. And thank you again to all of you for joining us today. And a special thank you to Deborah for organizing, for Macarena, for Juan, and for Alejo. And maybe someday we'll be dancing tango in a soccer match at the same time. But until then, take care. Thank you all.
Thank you very much.
Thank you. Thank you.
Very much
Thank you, Deborah. Bye.